Good evening to all my dear students. Most of the time, the questions that are asked from this subject are straightforward questions. Now, like any exams, when you have to answer those straightforward questions that are called sitter questions, you will have to be very thorough with certain pages of that chapter or certain portions of that chapter. And in all of these, brain death, organ donation, and ethics, you will find very voluminous books. And if you want to go through those books, it will be very difficult, all the more. But there are certain areas from which the questions are picked up. And if you scan through those areas before your exams, I think you will not miss the sitter questions. And the question paper setters are very careful because this brain death, there are certain complex issues involved in this, and the legislation varies from country to country. And although a lot of clarity has been achieved as of today, but still there are a lot of gray areas and there are a lot of differences in opinion. So those areas which have differences opinion are usually avoided for the sake of the exam. So that is one good thing about this. So we will cover in brief brain death, organ donation, and ethics. Now, ethics is particularly a broad chapter because it involves both ethics in relation to the ICU practice including organ donation, of course, and as well as ethics beyond the ICU practice, including ethics in research. So questions can be picked up from either of the areas. So certain areas of these are if you can remember it, then probably it will be useful in the sense. Let us start with brain death. Now, this is the WHO definition. And this definition has been modified several times because the first brain death, which was technically considered to be brain death, was first tasked in the year 1968. So from 1968 to 2024, 50 plus years, 55, 56 years. So a lot of changes have crept in, some surreptitiously and some consciously. And those changes have been accepted or rejected at different times based upon the reasons, both pros and cons. And what stands today is this WHO, the Global Glossary of Terms and Definitions on Donation and Transplantation. And here the brainstem death takes into consideration the issues which are related to transplantation. And therefore, this is the most acceptable definition that we have today. And you have to remember each and every line because some of these lines may get twisted and questions may be framed just to confuse you, to mislead you into answering the wrong option. So irreversible cessation of cerebral and brainstem function characterized by absence of electrical activity in the brain, blood flow to the brain, and brain function as determined by clinical assessment of responses. A brainstem dead person is dead, although his or her cardiopulmonary function may be artificially maintained for some time. Now, to note here is that the clinical assessment of responses. If you can underline this line, then you will find a lot of clues and a lot of questions can actually emanate from this phrase. So if from this phase, you can emanate what are the clinical steps of clinical assessment of responses, what do you mean by clinical responses, when is a patient considered to be in a coma, When do your patient is considered to have absent brainstem reflexes, etc., etc. So this clinical assessment of responses is something one needs to know, and one needs to know a little bit about the physiology pertaining to the coma unconsciousness and assessment of responses in this context, because all patients can with brain dysfunction can have some kind of unresponsiveness, but all unresponsiveness will not account for coma or not qualify as a coma. So brain death, if you can see on your left, is a complete, permanent and complete loss of all brain function in both cerebrum and brainstem. So note that these areas of the brain are distinct, one controlling the higher functions and another controlling the vital centers. So in cerebrum is language, responsible for language, memory, emotion, voluntary movement, and all the cognitive abilities. Brainstem controls breathing, heart rate, blood pressure, level of consciousness, etc. So loss of blood flow to the brain due to heart attack, stroke, bleeding in the brain. So most commonly the traumatic brain injury, the cardiopulmonary bypass, the cardiac arrest, these are common causes which are accounted for brain death, although brain death can occur after many more causes, including poisoning, etc. But whenever we consider diagnosis of brain death, these three conditions must be confirmed to declare brain death. One is that the patient is in persistent coma. There is no eye, verbal, or movement response to painful stimulus. Patient has no brainstem reflexes, that is, no eye response to light or cuff response to throat suction. And three, patient cannot breathe without assistance, that is, no breathing for 10 minutes without mechanical ventilation. Now, each of this can be elaborated at length. We will touch upon each of this, but broadly speaking, when you understand brain death and understand the definition in context to or in accepting all those things which are written on the box on the left side in with this image, then probably you won't miss anything. Now, as I said, whenever we diagnose from brain death to qualifying for organ transplant, that involves a series or sequence of steps. So some of the steps involve gross clinical assessment or gross clinical tasks, whereas some involve both clinical and technical tasks. So you have to understand each and every step and the role of an intensivist in each one of those steps as it moves on to the next step. Because if the first task is not complete, you cannot move on to the second. So you start with the neurological tests. When you confirm that this is an irreversible brain damage, the treatment futility or enforced prognosis has to be proven, because if the treatment futility is not proven, you can't go further. And there has to be consensus between the treating physician, the intensivists, the neurologist, etc. Next, identified as a medical suitable for organ donation. Suitability for organ donation is based upon a lot of complex criteria, and you have to know them. I will touch upon them in the subsequent slide. Consultation of the donor register, because with every place in the world, they have a donor registry, so that the candidate who is eligible to accept the organ is identified on the basis of that register. And only once the patient is registered is refusal, then you go to the next. Approach of the family members. If the family members of the brain dead patient needs to be approached, even if the patient has given his or her consent earlier, and there can be family refusal, of course. Of course, there are two different aspects, opt-in and opt-out donation. We're not going into this because that is technical and that varies from country to country, and therefore not too many questions you can expect from this opt-in or opt-out, because there are differences and debate among the legislatures upon this too. Next is the consent for organ donation. When the brain death organ is determined, if the brain death is not determined, that is not heart-beating donor, then we are identified, because there are two types of donors you can identify. So one is the beating heart and another is the non-beating heart, so NHB donor. Once the brainstem death is determined, then the heart-beating organ donor is identified. So these are all the steps which follow one after another, and only when the consent for organ donation has been accepted, you would go for all brainstem reflexes, EEG, apnea test, etc., as the case may be. Now, there are certain vital signs and general criteria which needs to be followed. One, the core temperature has to be maintained above 36 degrees centigrade. So, if active warming should be followed. Systolic blood pressure should be more than 100 with or without pressors. Absence of drugs that could simulate brain death, like the neuromuscular blocking agents, drug intoxication. We have to check the blood alcohol concentration. That should be less than 0.08% and so on. Next is absence of brainstem reflexes, which includes fixed pupils, absent corneal reflex, absent oculovestibular reflex, that is the caloric test, absent oculocephalic reflex, that is the Doll's eye, absent gag and absent cuff reflex. There should be absence of any cerebrally mediated response to auditory and tactile noxious stimulation peripherally and in the cranium. And apnea confirmed with the apnea challenge test, with no respirations with PCO2 of more than 60 millimeter of mercury. Now, if you go through it, you can very clearly understand that each of those reflexes, also that brainstem reflexes, you have to know it, at least the basic methodologies, because there can be some questions related to this. Let us we look into a few questions, some A-type questions. A 30-year man who had traumatic brain injury was declared brain dead. He's a potential organ donor and he progressed to shock. What would be your next appropriate step? The options are: administer methylprednisolone. It is associated with increased organ retrieval and it should be given as soon as possible. 2, myocardial ischemia is a common complication. All donors require angiography. 3, noradrenaline is the vasopressor of choice. It increases the vascular tone. And 4, or D, triiodothyronine, that is T3, should be given immediately administered in brainstem to prevent vasoplegic shock. So can anybody volunteer? You can unmute yourself and give your answer if you wish to. So Fatih Ischali has given an option of C. Well, the answer is A. Administer methylprednisolone because it is associated with increased organ retrieval and it should be given as long as possible. Now, vasopressin may reduce catecholamine requirements, but it is the vasopressor of choice. And MI is not common complication, but needed to be considered in patients having risk factors of MI and screening echo suggesting regional wall motion abnormalities. Not all donors will require angiography. It may be considered in those with HER donors. The iodothyronine, that is T3, can be considered to reverse hemodynamic stability, but not as a prophylaxis. And the corticope study showed no beneficial effect on graft recovery except during reducing the need of vasopressors in donors receiving hydrocortisone. But observational studies have demonstrated improved hemodynamic and status and oxygenation. So despite this, steroids are widely utilized tool for organ donor resuscitation, and therefore the answer should be methylprednisolone after excluding the choices B, C, and D.